For pregnancy and lactation professionals and parents-to-be, the First Exposure podcast offers safety information and clinical guidance about medications, drugs, and environmental exposures. Join us at firstexposure.ca.
Welcome to the First Exposure podcast. I'm Tali Bogler. I'm a family physician and chair of family medicine obstetrics at St. Michael's Hospital and medical advisor at First Exposure. Today, we're going to be talking about seasonal allergies. In this episode, we're going to explore how to manage seasonal allergies during pregnancy and breastfeeding. From sneezing fits to nasal congestion, allergies can be especially frustrating when you're already navigating the physical changes of pregnancy. We're going to break down what's safe to use, including antihistamines, nasal sprays, and practical tips for reducing exposure to common allergens. Alongside me are some experts in the field to discuss safe treatments during pregnancy and breastfeeding. And together, we're going to explore the latest evidence to help navigate some of the more common questions we have around allergies in pregnancy. The incredible lineup of experts joining me today are Dr. Samira Jeimy and Brenda Chang. I'm going to invite both of you to introduce yourselves. Dr. Jeimy, take it away.
Hello, I'm Samira Jeimy. I'm an allergist and immunology specialist based in London, Ontario, and I'm an associate professor at Western. I chair the OMA Women Committee and the Women in Allergy and Immunology group at the Canadian Society of Allergy and Clinical Immunology. So a big part of my work focuses on advocacy, especially around how allergic conditions intersect with women's health, pregnancy, and breastfeeding. I'm super glad to be part of this conversation today.
Thanks so much for being here. Brenda, I'm going to turn to you.
Hi everyone, so my name is Brenda Chang. I'm a clinical pharmacy practitioner at the St. Michael's Academic Family Health Team, part of Unity Health Toronto. I am also an assistant professor, status appointment at the University of Toronto, Maternity Medicine faculty.
Amazing. Thank you so much. And I will say Brenda is a wonderful resource here in our family health team for all questions related to medications and pregnancy. So thank you so much for joining us, Brenda. Okay, so let's get started. First question, and I'm going to ask Samira if you can answer this. What are seasonal allergies? And are they different from year-round allergens?
Seasonal allergies are also called seasonal allergic rhinitis or hay fever, and these are immune system reactions to things in the environment like tree pollen, grass, or ragweed pollen. These allergens are only in the air during certain times of the year, which is why symptoms tend to come and go with the seasons. What's happening under the surface is an IgE-mediated response. IgE stands for immunoglobulin E, a type of antibody that plays a very important role in allergic conditions. In people with allergies, their immune system sees something harmless, like pollen, as a threat and creates and releases IgE antibodies. The antibodies then trigger the release of chemicals like histamine, which then cause symptoms like sneezing or itchy eyes and congestion. Year-round allergens are also called perennial allergens. So these are things that are in the environment year-round. So dust mites, pet dander, mold, all work in the same way in that they trigger the immune system to make IgE antibodies. But again, these triggers are present all the time, not just seasonally. So the immune mechanism is the same, the timing and the management strategies can differ a little bit.
Thanks, Samira, for that explanation. So what are other conditions in pregnancy that can often feel similar to seasonal allergies?
Great question. So there are lots of different conditions that can mimic allergic rhinitis, especially in pregnancy. The most common is pregnancy rhinitis, which is driven by hormones, especially estrogen. So the estrogen actually can create nasal congestion without any underlying allergy. And you'll know that it's pregnancy related because it typically starts in the second or third trimester, and as soon as the baby's out, the symptoms resolve.
So what if they don't want to wait until the baby's out? So what is one way for someone to kind of know this is really pregnancy? Like, does anything else feel different than an allergy besides the nasal congestion?
Another excellent question. So if you have access to a friendly neighborhood allergist, you could always get allergy tested. The management of pregnancy rhinitis and allergic rhinitis in pregnancy tends to be very similar. So I'm sure we are going to talk about this later on, but the avoidance strategies and the pharmacologic strategies, they could be started even without any kind of testing. You could all try treating it as if it's an allergy.
Right. Okay, that's very helpful.
Which actually brings me to another very common cause of nasal congestion that I wanted to hit upon. It is called vasomotor rhinitis, and it is triggered by things like cold air, the wind, strong odors, perfume, or even changes in weather. So this is mediated by the autonomic nervous system, so the flight or fight system of the nasal mucous membranes. So activation of that nervous system component of the nasal mucosa actually make you have symptoms like nasal congestions or runny nose, but not necessarily the itchy eyes or the itchy nose or the itchy palate that you see with allergies. So allergies tend to be pathognomic with itchiness. These different conditions, they're not going to show up on allergy testing, so the clinical history is super important. And if someone has symptoms year-round with no clear triggers and no positive allergy testing, we start thinking in these sort of non-allergic categories. The last one I want to hit upon is that there could be a structural change in the nose that could lead to symptoms that can mimic allergies. So if you have, say, a septal deviation or nasal valvular collapse, the nose likes to have airflow up and down in a straight line. If airflow in the nose is turbulent, that actually triggers the nose to run and become congested. So you could have a septal deviation and it may, you might think you have allergies and then the allergy testing will be negative.
Deviation, you mean, just for anyone who's listening, is kind of sort of shifted to the side.
Yes, exactly. The middle of the nose is just a little bit off to one side. So one side of the nose might be working harder than the other. Last thing, very pertinent to pregnancy, is that acid reflux can actually make your nose congested. And a lot of people look at me like I'm crazy when I ask them about acid reflux in the allergy clinic, but that little bit of acid that travels up the back of the throat can actually stimulate your nose to run and be congested, particularly down the back of the nose. So we, colloquially say post-nasal drip. That can actually be mediated by acid reflux.
That's so important that you said that too, because we know acid reflux can become more common in pregnancy as well and be a nuisance in pregnancy. So it's interesting to think about how these can be connected, not something I often think about. And one other follow-up to your question, that natural nasal congestion that can happen in second and third trimester, I'm obviously very interested in this because it's just so common. Would those people feel itchy eyes and itchy nose? Because that would be also another way to maybe tell the difference between a seasonal allergy or environmental allergy versus the congestion that can happen in pregnancy.
Excellent point. So pregnancy brings with it actually lots of hormonal changes, like even perimenopause or menopause, bring with it a little layer of complexity because estrogen actually impacts the way that we make our lubricants for all our mucous membranes. So estrogen is actually very important in making the fatty layer of lubrication for eyes, for all different mucous membranes. So when there's fluctuations, you may actually get dry eyes, dry mouth, and that might manifest as itch. So a lot of individuals who have pregnancy-related rhinitis will say that they have itchiness, but that can be related to the estrogen.
Very interesting. Okay, so often people have these symptoms and say, I have itchy eyes, itchy nose, but how do I know what I'm actually allergic to? And so how would you address that?
Like in so much of medicine, the history trumps everything. So what is the timing? What is the location? What is the exposure pattern? All of those questions really guide us. And depending on those questions, we have something called a pre-test probability of allergy versus not allergy. We use skin prick testing or blood work. And by blood work, I mean we use something called serum-specific IgE or specific IgE antibody testing versus the suspected allergen. All of that testing supports the diagnosis, but only when there's a clear clinical correlation. Don't rely solely on the testing because false positives are very common, especially in people who have lots of different allergies and eczema. For pregnancy, sometimes people opt to hold off on testing unless results will significantly change management. There is a small chance of a allergic reaction with skin test. It's just so small that many allergists like myself don't really hold off on testing. I will often test. For me, the issue becomes around maybe a vasovagal syncope or passing out with the scratching that occurs during skin testing. So we will often have a conversation and we make the decision around testing in a shared manner.
But the results should be just as accurate in pregnancy versus not.
Correct.
There's nothing in the
Either-
pregnancy itself that will make the information less accurate. Is that correct?
I love that you clarified that. Yes, the presence of all that estrogen, progesterone fluctuation, it does not impact the fact that if you have an IgE antibody, it's going to show up on the skin testing and the blood test.
Super interesting. So someone who has environmental allergies, let's say before pregnancy, what can they expect potentially when they get pregnant? What will happen to their allergy symptoms? Can it get worse, better? What should they sort of be prepared for?
In so many areas of medicine, we have something called the rule of three. So 1/3 of patients will notice an improvement in their symptoms, 1/3 worsen, and 1/3 stay the same. That pattern is true of environmental allergies, and it's likely because of immune modulation in pregnancy. So the immune system is always balanced between too much an autoimmune type dominance or an allergic dominance, and there's always a balance between those two. So the allergy dominant individuals tend to have worsening of their symptoms. I guess the good news around all of this is that allergic rhinitis doesn't pose direct harm to the fetus.
That goes into the next question. Sometimes I find that people are worried I'm sneezing or coughing. I know we're not really talking about coughing right now, but I'm sneezing so much and I don't feel so well. How can this be good for my baby? What would you say to that?
That's actually a very important topic to cover. Asthma in pregnancy is this huge and important topic, but seasonal allergies, there have been no direct teratogenic or fetal risks linked to seasonal allergic rhinitis or year-round allergic rhinitis. The main issue is quality of life. So you can have poor sleep, you can have fatigue, you can have fatigue that's past the fatigue of pregnancy, and potential worsening of comorbid asthma. The last being potentially life-threatening. So those unmanaged symptoms can actually impact functioning. They can impact mental health. So it's important not to dismiss them as trivial.
Great, thank you for that. And Brenda, we're going to be turning to you in just a moment because you have an important role to play in all of this, and that's management. So how do we manage this? How do we improve people's quality of life when they're pregnant and have allergy symptoms? What is your initial approach when you see patients? What do you start with when we talk about management?
Typically, by the time that we see them in the subspecialty clinic, a lot of patients have been smartly started by their family doctor or primary care provider on avoidance strategies. So you start with allergen avoidance. So you keep your windows closed during peak pollen seasons. You use a HEPA filter. You change clothes after coming indoors. You use nasal saline rinses. So a lot of non-pharmacologic strategies are low risk, but they're effective. But when avoidance isn't enough, then medications can be used. I'll leave it up to Brenda to start discussing the medications.
Okay, great. Thank you, Brenda. I know because I'm one of them, and I know so many people turn to you for your advice on what is safe in pregnancy to manage these symptoms. There is this common fear among pregnant women and pregnant patients that they can't take anything to manage these symptoms. And so they just avoid everything. So what is your approach? What do you typically recommend both providers and patients that are pregnant?
Right. It is something that comes up quite often. One of the challenges is that, with medications, most of the packages for over-the-counter medications will say, if you are pregnant or breastfeeding, consult your provider. So there isn't a lot of guidance in terms of what to do if you wanted to self-manage. So on that point, I want to say that from a medication perspective, we have both over-the-counter medications. So those are the ones that patients can go into a pharmacy and self-select on their own without speaking to the pharmacist if they didn't want to, as well as prescription medications. And Dr. Jeimy talked a little bit about, one option being saline nasal sprays or rinses or drops. So those are in the area of medications in the pharmacy, but technically they aren't really a medicine because saline rinses or drops and sprays are really just a mixture of salt and water, and definitely safe. And they've been proven to be effective because saline nasal sprays and drops really do help clear the nasal passages and help reduce nasal congestion. So from a safety perspective, this is definitely a go-to for our pregnant patients or breastfeeding patients, and they can go to the pharmacy and get that on their own. I would say that there are a lot of over-the-counter medications that pregnant patients or breastfeeding women can also go to. So there's a number of different ones. The ones that probably most people are thinking about are the antihistamines. So these are the medications that you typically would use during seasonal allergy time. If you have hay fever, you want to go to. And what we know is that there's a couple of different kinds of these medications. We have some really old ones that have been around for a really long time. We tend not to use those, although we do have data to support that they are quite safe to be used in pregnancy. But the reason why we don't want patients to go and use those is because they're very sedating. And obviously, if you're pregnant, you're tired already, you don't want to be taking medications that will make you more drowsy. So now on the market, there are some that are the non-sedating ones. So some good examples would be medications like cetirizine or loratadine. We have a little bit less information about these medications in pregnancy, but overall, from all of the use over time and all the data that we do have, we know that they're fairly safe, and it is okay for patients to go and take these medications. Now, of course, these are still medications that you take by mouth, and so people are worried about that. I'm ingesting it, it goes into my blood, and then it's going to go to my baby. So I want to say that the amount absorbed is still fairly low, and we have some data to show that, overall we don't think that it is risky. But of course, if patients are really concerned about that, we do have other options that are not by mouth, right? Not tablets that you take. And so one good example of that would be nasal sprays. So we have some steroid nasal sprays. And for nasal sprays, they used to all be prescription medications only, but now we do have some that are also over the counter. And these nasal sprays, because they're steroid medications, they help to decrease inflammation, they'll help to reduce congestion and help with that postnasal drip that we talked about earlier. So they are helpful for patients with allergy symptoms and can definitely be considered. And sometimes, some patients have really specific symptoms, like just for their eyes, like, itchy eyes, red eyes. So we know that eye drop medications that are over the counter can also be safely used in pregnancy if a patient really wants to, and that's okay. We have enough information to say that those are safe to be used as well.
May I add a few points?
Please. And especially the over-the-counter intranasal corticosteroid. I'd like to talk about that a little bit more too. Samira, take it away. So what do you have to add to that? That was great, Brenda. Thank you.
I have two things to say. One is going to be a little bit controversial, I guess, and that's to examine the root cause for why things are not recommended for pregnant individuals and those who are breast or chest feeding. So historically, certain groups of people have been excluded from the clinical trials. This includes kids, this includes people of color, this includes pregnant individuals, as well as lactating individuals. So it's unfortunate that the exclusion actually is perpetuated in perpetuity by having monographs on products that say cautious of using it in this population without using some medications in the real world off-label on certain groups of people. We will never have so-called clearance to use these products. So in that same theme, in the pregnant and lactating individual, I do not hesitate to use medications that have a clear and robust safety record. So that includes things that like rupatadine or belastine, which are newer and they're used in infants. So that the safety profile is very reasonable. So those kinds of medications are an excellent add-on to things that have a longer history of safety, like loratadine and cetirizine.
Can we talk about the intranasal corticosteroids that you can get over the counter? First of all, they're very expensive. I think they're about $50. The other thing is, so now knowing it's over the counter, and if people can afford it, should they go get it? Should they get a prescription? Should they see their physician first or whoever is caring for them in their pregnancy?
I've seen in some pharmacies where they're locked. because they're an expensive item, even though they're over the counter and you can self-select, some pharmacies have chosen to lock them up. So you actually do have to interact with the pharmacist. You have to ask them to unlock it for you to purchase. So I would say that for our patients who have drug coverage, who have good drug coverage, a prescription would be very reasonable. We have a number of intranasal corticosteroids that are available on prescription, and most private third-party drug plans would cover these agents without any issue. Obviously, for the people who don't have a drug coverage, then over-the-counter is still an option. Because we know overall, intranasal corticosteroids have very low risk of side effects. In fact, most people would not complain of side effects. And then the other thing is that even though they're nasal and not inhaled, from our data with asthma patients who use inhaled steroids prolonged, and they've been using it for a long time, we know there's quite a lot of safety data for using steroids in that population. So some of the information we have is extracted from the asthma population to know that these are very safe to use and recommended. Yeah.
Thank you. Samira, you wanted to add to that, I think.
Yes, I'm itching. Cost-wise, Brenda's the real expert here, but when it comes to side effects of nasal steroids, one major thing to remember is not a lot of people get taught how to use it. So it's difficult for me to convey this in a podcast if you're listening, but remember to always stay away from the middle of the nose where all the blood vessels live. So you are going to point the spray outwards towards your ear. I tend to cross my hands, so I use my right hand to point towards my left nostril and ear, and vice versa. One other thing to remember is that if you taste the nose spray, you waste the nose spray. So if you taste it, you waste it. Having that big sniff in when you use a nose spray, practice taking either short little sniffs like this or no sniffs at all, because you want the spray to stay in the nose, and that will minimize side effects for a large proportion of people. The other thing to be aware of is that a lot of the side effects from the nose sprays come from the excipients or the preservatives that are in the nose spray. So one common one is called benzalkonium chloride. Depending on how much of that preservative is there, you may develop some mucous membrane irritation. So if you use a nose spray and you just hate the smell of it, you hate the taste of it, it's irritating you, don't give up on nose sprays altogether. There might be an option that works for you. Going back to actually the saline spray, I just want to make like a one safety note. I think that might be a personal preference, but I prefer that my patients use either distilled water or boiled water that is cooled for the nose sprays. Although very, very rare, there have been some cases of parasitic infections from using tap water with the saline rinses. So everything has a side effect, but I think we can definitely have a shared discussion with your pharmacist, with your family doctor, with your allergist to minimize those risks for you as best we can.
Going back to that original question that I had, how to tell the difference between the nasal congestion versus how do you know if this is an allergy in pregnancy, how would you approach your treatment? Like, would you start the patient on a saline rinse and then go to, do you have a ladder approach, or do you kind of try it all?
By the time a patient comes to me, I tend to start with medications because they typically have already tried nasal rinses and their symptoms are bothersome enough that they've waited the 12 to 18 months that our Canadian healthcare system makes them wait to see us. So I usually start with a nasal corticosteroid because regardless of the source of the inflammation, the corticosteroid will help with that inflammation. So I tend to start with that, and we start the discussion around the more definitive therapies like allergen immunotherapy, whether they be via tablets or injections, at that first encounter most of the time.
Okay, so let's turn to that. Let's talk about that. So allergy immunotherapy, injections, as people say, can you continue in pregnancy or while breastfeeding? Samira, why don't you answer that for us?
So allergen immunotherapy was traditionally thought of as just allergy shots. I think it is important for us to highlight that there is also a tablet option now for allergen immunotherapy. It's called sublingual immunotherapy, or SLIT. So both of those modify the immune system and essentially make you make neutralizing antibodies against those IgE antibodies that I brought up before. So in terms of the safety, shots and sublingual immunotherapy, they're essentially exposing you to things that you're allergic to. So there's a risk of allergic reactions with the treatment themselves. So most allergists will not start an individual who's pregnant or lactating on allergy immunotherapy. But if somebody is already on maintenance, so somebody has done the build-up phase of immunotherapy, then most of us will actually, depending on the decision of the patient, maintain the patient often on a lower dose during pregnancy. The risk of systemic reactions vary because your hormones are always fluctuating. So it is really important to have a very detailed discussion with your allergist managing that.
Okay, great. Thank you. Can we turn to breastfeeding, lactation? So now, somebody's delivered. They're in their seasonal allergy period, whenever that might be for them, and they want to know what's safe to use while breastfeeding or lactating. Brenda, can you answer that for us?
Sure, I'll start. So definitely the saline nasal sprays and rinses can be continued to be used when somebody is now postpartum and breastfeeding. So those are, again, just as a reminder, just really salt solutions, so they're definitely safe. But of course, if you're using the rinses, like Dr. Jeimy said, it would be best to use distilled water or boiled water that's been cooled down to room temperature or lower, so that it's more tolerable for use as a rinse. The non-sedating antihistamines, what we do know is that small amounts do transfer to the breast milk, but they're not expected to cause any major risk or sedation or worsen sedation for the most part. Sometimes we will, advise to be cautious with using very large doses. And the reason is because we've seen that, and it may be because of the fact that some of these were combined with other medications like a decongestant, but high doses of these sometimes can impact the amount of breast milk that's made. So certainly small amounts of antihistamines, non-sedating ones would be very reasonable to use during breastfeeding. And, with nasal corticosteroids, again, most of the ones that are available now are very tiny molecules. So with tiny molecules, very little is absorbed. And, medically, we call that bioavailability, like how much is available to us in the body. And those are quite low. And so if they're low, even in our bloodstream, there's even less that goes to the breast milk. So the overall concern around using those for breastfeeding is very small. And it's the same with eye drops. So allergy eye drops, definitely patients, we feel very comfortable to say if they needed to use it for a short period of time, if they're breastfeeding, that's okay.
Okay, great. Thank you for that. Brenda, I have a question for you, and that's in terms of decongestants. A lot of my patients or people that I know think that a decongestant is going to fix everything that's happening up here. Is that something we typically use for allergic rhinitis or seasonal allergies? And would you use it in pregnancy?
That's a great question. Oftentimes when patients present with symptoms of congestion, they're always thinking about, what I need is a decongestant. You can have them in a nasal spray or as tablet medications, but it's really important to know that, the inhaled corticosteroids, the nasal sprayed ones, are meant to treat congestion. And the ones that we have over the counter that are actually categorized as decongestants might not always be good to use in the setting of pregnancy. So the ones that are over the counter, sometimes people will confuse that decongestant with like the saline nasal spray even. They're actually in the pharmacy, usually kept in the same area. What we know about nasal decongestants, sometimes even in the setting of outside of pregnancy, is that sometimes patients overuse those and they get rebound congestion when they come off because they've relied on it so much and it just makes their congestion worse.
Great, thank you for that. Samira, anything to add to that?
I think one other point to add would be that continued use of a decongestant actually causes dependence on them. So there's this urban legend out there that I often encounter when I try to prescribe a nose spray, in that a patient will say, oh, but I read that you can become hooked on them. Yes, you can on some of them. So if you use a decongestant, your nose actually becomes dependent on the decongestant to remain uncongested. So when you stop the decongestant, you actually get something called rhinitis medicamentosa, or rebound nasal congestion.
Thank you for that. And would you say the same for an intranasal corticosteroid, that dependence?
No, so mechanism very different. So thankfully, we don't see that phenomenon with nasal steroids.
That is a very common question I get in my practice. Well, can I continue taking this nasal steroid? I mean, forever or for months? And so that's really great that you clarify the difference between the products. Okay.
I think that patients should know about the nasal steroids and the nasal decongestants is that the nasal steroids take a little bit of time to work. So they don't work right away, whereas the nasal decongestants usually work fairly quickly. And so that's sometimes the reason why people want to use the decongestant because they feel relief right away. But it's really important to let people know that if you're using a nasal steroid, it does take a little bit of time to see the full benefits. Don't give up on it. It is supposed to be used as written, if it's twice a day, use it twice a day and continue, and then they'll see.
How long, when you say it takes a little bit of time, what are we talking about? Hours, days, weeks?
Well, I would say usually you need to have like 2 weeks of consistent use to see the benefits, but Dr. Jeimy, if you wanted to add anything here.
It takes about a week of regular use twice a day just to notice anything. But I wanted to add that there are actually 2 different options available by prescription only for now in Canada that have an antihistamine component in them. So it's a nasal steroid antihistamine combo. One of them is pricier than the other. To me, one of them has a little bit of a stronger smell than another. Those are actually options to try that do kick in right away when I'm trying to get somebody off of a decongestant and onto a nasal corticosteroid. I often use those combo medications as a bridge.
And you say they work right away because of the antihistamine component to it? Interesting. I didn't know that. That's great. Thank you for that. And do you find that some patients, even with an intranasal corticosteroid, although it might take 2 weeks, they might even see some benefit within days?
Plus minus, there's an effect called priming. So if you start to use a nasal steroid in the midst of having a terrible allergic season, you're going to have a harder time getting that inflammation down. Whereas if you are headed into, that your seasonal allergic rhinitis season is coming up, if you start to use a nasal steroid about 2 weeks prior to the onset of the season, it turns on really quick because your nose is just happier to begin with.
Great. Thank you. These are very practical tips. I appreciate all of them. I want to turn to you, Samira, and just walk us through if I was a patient, let's say, and I'm in my 2nd trimester and I know I have seasonal allergies, what can I expect when I go see my primary care provider or midwife potentially, or whoever is caring for me in my pregnancy? What can I expect in terms of the overall management, what I should start with, and what the other potential options are for management?
So when you come to an allergy clinic or a family doctor clinic, the first thing we do is listen. We start with a detailed history of what symptoms you're having, when they happen, what seems to trigger them, how much they're affecting your life. So that part is just as important, if not more, than any test that we do. In the allergy clinic, then, if we suspect that you have allergic rhinitis or another allergy-driven condition like asthma, we might offer skin prick testing or blood testing to look for those IgE antibodies that are markers of allergic sensitization. But we interpret them pretty carefully because a positive test, as I mentioned, doesn't always mean you're truly allergic and vice versa. So context really matters. And then once we know what you're reacting to, or if you confirm that you're not allergic, we then go through a treatment plan. So this usually includes a stepwise or ladder approach, starting with environmental tweaks that you can make to reduce or eliminate your exposure. Then adding medications like antihistamines or nasal sprays if needed. And then for people with more persistent and severe symptoms, we might discuss allergen immunotherapy, which retrain your immune system over time to tolerate your allergens. So the goal isn't just to throw meds at you, it's to help you understand your immune system and feel better on a day-to-day basis and give you a sense of control.
That's great. Thank you. I love that explanation. Brenda, anything to add to that?
No, I think that was great.
Okay. That brings us to the end of today's episode on seasonal allergies in pregnancy and lactation. We've covered a lot of ground, lots of practical tips that I so appreciate, and I know our followers and our listeners will appreciate as well. So huge thank you to both of you for sharing your time and knowledge by answering these really common and critical questions. For more resources, visit firstexposure.ca. And I would like to add that Dr. Samira Jeimy wrote a wonderful health topic on seasonal allergies and in pregnancy and lactation that you can find on our website. Again, thank you to our listeners for joining us. If you found this conversation valuable, be sure to subscribe, share, and stay connected for future episodes.
The First Exposure team acknowledges that our office is based on the traditional territories of the Anishinaabe, Wendat, Haudenosaunee, and the Mississaugas of the Credit, though the impact of our work can be felt across Turtle Island. First Exposure is committed to nourishing respectful relations with Indigenous communities whose knowledge of medicinal plants and environmental substances are a foundation of the pharmaceutical science on which First Exposure depends. This project has been made possible thanks to the vision and support of the Vora Miller Foundation and the participation of the Dalla Lana School of Public Health at the University of Toronto and Health Nexus.